landmark down here. What is that called? Gluteal fold. If I palpate into that gluteal fold, what am I going to find?
Ischial tuberosity.
Ischial tuberosity. All right, so I'm going to do that. I don't have to like poke around. I just put my thumbs in there. I push straight down, and sure enough, I'm right on them. Good. All right. Then, if I know where the iliac crest is, remember the iliac crest, the gunslinger? Iliac crest. Middle finger is what? Greater trochanter. So if I can do it this way, I should be able to do it this way. I just simply grab the SIS with the tip of my middle finger, come down with the heel of my hand, and sure enough, you feel that? There it is. Same thing on this side. There it is. I've got my greater trochanter. All right. Then there's a couple of ways that we palpate the PSIS and SI joint. We have the dimples. Now, the dimples are hard to see if you're looking straight on unless they have a lot of fat. Then they're easier to see. But if they don't, if you look at them from the side, can you guys see her dimples?
I see dimples.
Yeah.
We know that right in those dimples is the PSIS. Now, occasionally you'll have a patient that doesn't have the dimples. So then you got to palpate. But we know that from the L4, L5 interspace, we just go down about 2 fingers worth, and then we say straight across from that will be, or you can say let's follow the iliac crest around until we find them. But now, huh?
The other way was so much easier though.
Yeah, it is if you got the soft tissue landmarks, but
True.
you don't always have soft tissue landmarks. Once I find the PSIS, I go underneath and push up. There they are. And I can palpate them here, but I can also, in standing, assess their height. Because I might have it doing this, and so this one, the ASIS will be lower, but the PSIS will be higher, and we call that an anterior rotation. And so I will fix that. It's unilateral. I will fix that with different mobilizations or muscle energy treatments. Good? It may be that this whole thing is slipped up. We call that an upslip. ASIS is higher. ASIS is lower. Sorry. ASIS is higher. PSIS is higher. The whole thing upslips. Now, how do I know if this one is upslipped or this one is downslipped? Then we base it on pain. I got pain on this side, so whatever this one is, if it's higher, it's an upslip on the painful side. If this side is painful, then it'd be a downslip on this side. Good? I can also have the ASIS on one side be higher and the PSIS on that same side lower. We call that a posterior rotation or a posterior torsion of the unilateral innominate. Remember the innominate? We call that pelvis. One side is an innominate. Then I want the SIJ. S, sacral, I, iliac, J, joint. So SIJ is what you'll see documentation-wise. Sacral iliac joint, all I do now is once I find the PSIS, I'm not trying to palpate the actual joint. I can't because all these ligaments come from the iliac crest or PSIS and go to the spinous processes, boom, boom, and form what we call the posterior sacral iliac ligament. But we know that if something's wrong with the joint, the ligaments will be overstretched or understretched, and so we palpate in that space onto this soft tissue. And if I poke in there and it's painful, I know I've got an SI joint, or I likely have an SI joint problem. If it's not painful, then we say it's normal. It's not painful on anybody unless something is wrong. So I find the PSISs, we'll say on the right side, I go medial to that. Is that painful in there at all? And so I know nothing's wrong with the SI joint, most likely. Good? So then I go to muscles, and I think I covered all of the bones. Yes. So the muscles, not that you are not concerned with all of the muscles, but the common ones with back problems, in the hip, it's the piriformis. So how do I palpate the piriformis at on the right side? I want to find that. I need my other landmarks, right? I need my L4, L5 interspace. If I put my heel of my hand, boom, my middle finger should be right on my coccyx, right in that what we call vertical gluteal fold. Good? This will be your horizontal gluteal fold. This will be your vertical. I don't need to press down with that. I just know that that's the coccyx, so therefore my hand and fingers must be the sacrum. So now I know where the sacrum is because I know the anterior surface of the sacrum to the tip, crest, or summit, depending on what Steve taught you, is the piriformis, correct? So now I know where the sacrum is. Now I know where the greater trochanter is. I just move to the tip of it, or the summit, or the crest, right there. I know somewhere in that region is my piriformis. Now, can I feel that piriformis? You can if you are a great palpator. But I don't need to palpate it if nothing's wrong with it. If something's wrong with it, it's spasming. If it's spasming, then it's easy to palpate and it's tender. So I go transverse. Remember, I'm always trying to strum muscles, right? Like a strum a guitar string. So far, so good. And if I want it to contract, I want her to push her foot out, or I want her to pull her foot in. That would cause her to internally rotate. Is the piriformis an internal rotator or external? So I'm going to say, don't let me move you. I'm going to try to push her out, and this is why I always got confused in school. I'm pushing that way, but she is contracting and trying to go this way. I don't want her to win. I'm not trying to get an isotonic contraction, so the easiest direction is to say what? Don't let me move you. That way, I'm in control of how much I push. Otherwise, every patient wants to win. They try to move you. All right? So, Kristen, don't let me move you, okay? And then I can, with my force, make it mild, moderate, or a bigger strong contraction. Don't let me move you. And relax. Don't let me move you. And contract. Relax. Don't let me move you. And relax. I feel it a teeny bit. And I've done this for a while. It's not that I'm perfect, but do you have any tenderness in this area?
No.
There's nothing wrong with it, so it's not spasming, it's not tender. So I know, hey, I just ruled that out. That's not the problem. The SI joint is not the problem. Now I can focus on other things. But I have pain down in my buttocks. Is that the piriformis? I don't know. Let's check it out. I check out the piriformis manually with a resistance. How do I check out the iliopsoas? I palpate it in the hook line position. How do I know if it's tight? Remember this from last quarter? Thomas test. Remember the Thomas test? And Eli's test. Eli's more for rectus femoris, but definitely Thomas test. Good? Now I've ruled out iliopsoas, I've ruled out piriformis. Now I'm looking specifically at specific back muscles. There are two groups. One that go from inferior medial to superior lateral, like a true V, or the ones that go from inferior lateral to superior medial, like a Christmas tree. I go from a V to a Christmas tree. Good? The superficial ones are like a V, or the superficial ones are like a Christmas tree. V. The superficial ones are what three main muscles?
I love spaghetti.
I love spaghetti, which stands for iliocostalis, going from lateral, longissimus, and spinalis. The deep ones are what? Multifidus and rotatories. Now, if you can palpate the rotatories in the lumbar spine, you're better than me. They're deep to the multifidus. Multifidus is about that thick on most people. So now, if it's that thick, plus, now, Kristen is awesome. hardly any fat on her. That's not the norm in the clinic. But even if it was Kristen, with hardly any fat, and we've got a multifidus that is that thick, can I ultrasound and get to the facet joints, get to the disc? Too deep. What's the deepest I can go with ultrasound?
3 inches.
That was iontophoresis. Shoot.
Got 3
5
inches.
centimeters, which is approximately
3 inches.
2 inches,
2
2.54 centimeters per inch. So 2 inches or 5 centimeters, whichever one you want to memorize, memorize that one. I always have a hard time with metric. You know, anyone from the United States have a hard time with metric system. But that is already 2 inches, and I haven't even gone through any fat, or I haven't gotten to the facet joint either. I haven't gotten to the rotators. So I want to start lateral, and I find my iliac crest, and all I do is start poking in, poking in, poking in, poking in, and moving my way around medial to the spine. So I poke in, poke in, poke in, poke in, poke in, poke in, and then I feel a tight, you feel that tight structure? The first one I come to is the most lateral, but it's still deep. That is the what? Quadratus Lumborum.
Wait,
Right?
what?
No, Quadratus Lumborum, because we're in the lumbar spine. If it was Quadratus femoris, it'd be down by the femur. So I find the iliac crest, I come up, and then I start digging in, and as I'm digging in, I'm working my way around like this. And the first one I come to is a thick sheet of muscle. You feel that? Quadratus Lumborum. Then I keep coming, and I have to come posterior up and around when I hit the next one. When I hit the next one, and sure enough, do you feel that? That one is the most lateral of my I love spaghetti, so that is the iliocostalis. And the one that, go ahead and look up towards Mark, Kristen. The one that pops up, that is your longissimus. I'm not saying that none of it is the iliocostalis, but what you see is the longissimus. Thank you. So that's a nice way of helping, have the patient just, can you gently lift your head off of the mat for me? That's all she has to do, is just gently lift the head, and that activates the whole spine. So that's going to be important to know. Then, I want to go medial, but I can't feel the spinalis unless I find the spinous processes, and then I know where the longissimus is, and then I try to push it aside, like that, and then dig down right next, or just on the lateral side of the spinous process. Then that is my spinalis. That is not commonly strained, so it's not commonly needed to be palpated. But one last thing I want to point out, with treatment, I know we haven't even gotten to pathologies yet, but we will tomorrow, but we're going to be treating the lumbar spine. What are the biggest problems in the lumbar spine as far as you know right now? Functional segmental units. L4, L5, and L5S1. I'm not saying you can't injure above that, but that's probably what boards are going to ask you. That's probably going to be half the questions I ask you. I'll throw in a 3-4. I might throw in a 2-3 just to keep you honest. Probably never throw in a 1-2. That I've never seen one. They happen, but rare, rare, rare. And it's usually not from a disc or injury to that particular joint. It's usually due to a cancerous lesion that grows between T12 and L2. So, there is my low back. Not to be picky, but just think what way back when you first got here, where did you apply your electrodes? So they crossed like that. Were you getting good pain? Would you get good pain relief with that? No. You're not dealing with the part that's injured. Now, if I injure this part, I might have all of these muscles up here spasming and tight. I'm not saying you can't treat that. But let's treat the core of the problem, the actual injury site. If I want to do ultrasound to the multifidus, the longissimus, how big of an area can I ultrasound effectively with thermal tissue temperature rise?
3
Two times the, not, the head is close. The ERA, which is almost as big as the head. If you use the head, close enough. Clinically, we use the size, but if they ask you, it's 2 times the size of the ERA. Good? So, average size of a ultrasound head is 5 square centimeters. So that's about 10 square centimeters. It's perfect for low back. But what do you see in the clinic? There you go. Right? As long as you use warm gel, it feels good, right? It's like a little light massage. But all we need to be concentrating on is one spot with a specific muscle strain. I'm not saying you don't apply the heat pack and relax the whole back. I'm not saying you can't do any soft tissue, but let's get to where the problem is. So if you take care of this problem, the rest of this will take care of itself. Good? All right. So we've got Piriformis, we've got Quadratus Lumborum, we've got Iliocostellus, Longissimus, try to feel spinalis. And then in that L4, between S1 and L4, find the spine and push the longissimus aside and try to go deep and feel, oh yeah, there it is. You feel that? Right in there. Try to feel the deep multifidus. Good? You know it's not the longissimus because you're pushing it aside. Spinalis doesn't go that low. I don't know if you remember the picture in your handout. You can re-look that up. Spinalis is not that low. Spinalis starts right around here. So you're going to be on multifidus. If I'm below the longissimus, I'm on multifidus. Good?